Pleasant day, dear doctors, and welcome to this intensive Blitz review in correlative anatomy and surgery. So for this session, we're going to be taking up the esophagus and the small and the large intestines. Now, before we proceed with our lecture proper, I would just like to share this caption with you. I have confidence in the one who leads the way. Lord, with you as my guide, I know my destination is sure. Thank you for the assurance that you are constantly watching over me, leading every step that I take. I often stay from your path, O Lord, but time and time again, you have redirected me. Thank you for being my guide in life. So continue to be grateful and always pray before you study. And let's pray for fruitful results. Now, these are the official references that I'm using for this module. You will notice that it basically has all of the anatomy references in the syllabus, from Clinical Anatomy by Regions by Richard Snell to Moore's Clinically Oriented Anatomy, plus, of course, our ever reliable Frank Netter Atlas, and some recent things that popped out, which were particularly about BRS anatomy. Now, I am putting in some Principles of Surgery Swartz, as well as General Surgery Absite, and some entries which were lifted from Harper's Biochemistry, which actually were the references used for the actual questions that came out. Okay, so stick with this module. It's a tedious one, but rest assured, it's very high yield and it's going to make your life so much easier. So let's start the ball rolling. So from Clinically Oriented Anatomy by Moore, this is chapter 5, the abdomen. It's a part 1 and a part 2. Okay. Now, when a lot of us approach anatomy, this is usually what we experience. Okay. And for this module and all of our other modules with me, you're going to experience the complete opposite. Okay. So we're going to stick to the must knows and the must master. So for this Blitz session, we're going to take up the esophagus and the small and the large intestines. So we're going to start with the esophagus first. Okay, again, we're going to start with the esophagus first. Now, let me just give you an overview, okay? An overview of basically what's found in your textbook. So it shows to you, okay, it shows to you there everything in the abdominal viscera. So we're going to take up the esophagus. We're going to take up the ileum, okay? We're going to take up the jejunum. So that's the small intestines. And we're going to take the entire large intestines from the cecum to the ascending colon, to the transverse colon, to the descending colon, until we reach the sigmoid. We have a separate session for the rectum and the anus. Okay, so again, we have a separate section aside from what we're taking up right now. Now, I lifted this image from osmosis.com, this is a beautiful image. Now, before we go to the organ systems, I want to mention in passing the embryology because there were a couple of questions that came out here. So the primitive gut is divided into the foregut, the midgut, and the hindgut. Fore, mid, and the hindgut. Now you have to remember that the foregut actually begins from the esophagus. It is from the esophagus to the duodenum. The midgut also begins from the duodenum, the lower half of the duodenum. So your landmark for the foregut and the midgut is the duodenum. So basically the foregut would be the primitive structure that would give rise to the esophagus, to the stomach, to the proximal. Take note, it's the proximal duodenum, the liver, the gallbladder, the pancreas, and the spleen. So the hepatobiliary system arises from where? Foregut, midgut, or hindgut. So answer my question. Where does the hepatobiliary system arise from? Saan galing yung hepatobiliary system? Okay, the hepatobiliary system comes from the foregut. Now, I want you to remember, okay? I want you to remember, okay, that you have to differentiate whether it's the proximal or it is the distal duodenum, okay? Whether it's the proximal or the distal duodenum, because the foregut is the proximal duodenum. The midgut is the distal duodenum. So all of the structures you see here on your right, these are the structures, okay, the abdominal viscera, which arises from the foregut, okay? Now, here's the foregut structures. Here's the midgut structures. Here is the hindgut structures. So I want you to remember that from the distal esophagus to the proximal part of the second duodenum is the foregut. From the distal half of the second part of the duodenum, going down to the proximal 2/3 of the transverse colon, that is the midgut. And from the distal 1/3, kasi proximal 1/3 of the transverse colon, you now have the distal 1/3 of the transverse colon going all the way to the rectum. That is the hindgut. So again, take note, distal esophagus, okay, going to the proximal second part of the duodenum. That is the foregut. So it is now distal second part of the duodenum all the way to the proximal 2/3 of the transverse colon. Then the distal transverse colon going down to the rectum. Okay, so please take note of this. So please take note of this. Okay. You have to be familiar with this. Now take note, the blood supply will also depend on whether it's a foregut, midgut, or a hindgut structure. Now here, label letter C for the cecum. This is now the ascending colon. This is the transverse colon. Now, what flexure do we call this? This one here. What flexure is this? Is this hepatic or is this the splenic flexure? This is the hepatic flexure. It's on the right side. The liver is here. Now, what about this portion here? What flexure is this? This flexure is now the splenic flexure. Now, tip, always remember the cutoff of the blood supply is here at the junction of the splenic flexure and the transverse colon. Everything you see here on the left side is superior mesenteric artery. Everything you see here on the right side, this is inferior mesenteric artery. Now, there is an area, okay, this is a surgeon's pearl as well as an internist pearl. The area which is most prone to ischemia, usually because of mesenteric ischemia or atherosclerosis, is usually in this area here. What do we call this area, which is the most vulnerable to ischemia? It's named after a person. This is known as Griffith's point. Griffith's point is the point most vulnerable to ischemia. Okay, we call it Griffith's point. So please take note of this. Okay, again, please take note of this. Griffith's point. So please take note of this. Okay, now I made this table. It's a very, very busy table. Okay, so please refer to your study guide for this. It's a busy table, but it basically summarizes everything. So I give you the assignment to study the foregut derivatives, the midgut derivatives, and the hindgut derivatives. Now, let's just say the exam is 5 minutes from now. What does Dr. Toom recommend you study? Number 1, foregut, midgut, hindgut. Memorize the following landmarks. Duodenum, duodenum. Foregut derivative is what part of the duodenum? Proximal or distal? Foregut. Ano yung foregut? Is it proximal duodenum or is it distal duodenum? What is the foregut? Foregut is proximal duodenum. What about midgut? Ano yung midgut? Midgut is now distal. Okay, that is what you should memorize because it's the boundary between foregut and midgut. And what is the boundary between midgut and hindgut? It's the transverse colon. Proximal 2/3, memorize that, basta midgut, and memorize distal 1/3 for the hindgut. Okay, one more time. What should you memorize for foregut? It is the proximal duodenum. There are 2 things to memorize for the midgut because it's right in the middle. Memorize distal duodenum and memorize proximal 2/3 of the transverse. For hindgut, it's enough to memorize the distal 1/3 of the transverse colon. So please take note of that. Okay, again, please take note of that. Those are the things you need to memorize. Okay, now let's move in to the pearls about the esophagus. Remember, you are joining an intensive Blitz review. There is a presumption you have read this already. Okay? Review, not preview. Study the detailed lectures in your ECDB. Okay, study the detailed lectures in your ECDB if you have not read this yet. Okay, so let's go on with the esophagus. So what are the basic characteristics that we should remember? Number one, it's roughly about 20 to 25 centimeters long. Okay, it is the most muscular segment of the entire alimentary tract. The alimentary tract begins with the mouth. Okay, the alimentary tract begins with the mouth. Okay, for the epithelium of the esophagus, it is stratified squamous. Okay, and please take note, it is non-keratinizing. Okay, it is non-keratinizing epithelium. Can you tell me what organ is keratinized? This is a no-brainer. What organ is keratinized? Okay, great. It's the skin. So stratified squamous keratinized is the skin. Stratified squamous non-keratinized is the esophagus. Now, the esophagus has the thickest muscularis mucosae in the alimentary tract. Now, can someone tell me what layer, what histologic layer is missing in the esophagus? What layer is missing in the esophagus? Okay, the layer that is missing, okay, missing serosa. So what is the significance mentioned in Snell if the serosa is missing? So what if the serosa is missing? What is the clinical significance if the serosa is missing? So number one is the spread of infection is easier. Number two, the spread of cancer is also faster or easier. So metastasis. So please take note of that. Now, everyone has to memorize that the esophagus is divided into three parts. What are these three parts? Cervical, thoracic, and abdominal. So again, what are the three parts of the esophagus? Cervical, thoracic, and abdominal. Okay, so please take note of this. So what are the three parts of the esophagus? We have the cervical, we have the thoracic, and we have the abdominal. Now, tip, what separates the thoracic part from the abdominal part? It is what structure? What structure separates the thoracic part of the esophagus and the abdominal part of the esophagus? Very good. It is the diaphragm. Okay, the diaphragm. Now, let's try to add more things which you need to bring with you to the exam. The esophagus has three constrictions. What are these three constrictions? We have the cervical, we have the bronchoaortic, which is also known as thoracic, and lastly, we have the diaphragmatic. Now, what is the clinical significance if there is a constriction? So what if there is a constriction? What is the clinical significance if the esophagus has a constriction? Let's see your answers. Okay, I hear regurgitation, obstruction, foreign substances, foreign body, okay, strictures, place for obstruction, dysphagia. The best answer is obstruction. Okay, the best answer is obstruction. And yes, it is correct that these constrictions can also serve as landmarks. Okay, so the best answer, the significance of the esophageal constrictions is landmarks. Now, tip. The first constriction is at the cricopharyngeal or the pharyngoesophageal level. Then we have the second constriction, which is at the level of the aortic arc. And as the bronchus splits, we have the left and the right main bronchus. The third constriction is as the esophagus passes through the diaphragm. Now, common question in exams is they ask you the distance from the incisors. Nasogastric tube insertion, endoscopy. This is the significance. Now, question. What do we call that area between the cricopharyngeus and the inferior constrictor muscle? What do we call this weak area here? I gave you a hint. It's a weak area. This is known as Killian's triangle. So what is the significance of Killian's triangle? Killian's triangle is the weakest portion of the esophagus. Therefore, this is where perforation usually occurs. At the same time, this is where a diverticulum would most likely occur because it is the weakest portion. So it's found right between the inferior constrictor and the cricopharyngeus muscle. So perforation can occur there, and it's usually iatrogenic. Okay. Now, question. At what level would you encounter the esophageal opening of the diaphragm? At what level would you encounter the esophageal opening of the diaphragm? This is more or less at T10. So how many letters are in the word esophageal? How many letters are in the word esophageal? Okay, it is 10 letters. And what is the cranial nerve that also passes through the esophageal opening? What is the cranial nerve that also passes through the esophageal opening? Okay, very good. It is also cranial nerve 10. So the magic number is 10. So it's the vagus nerve. Now, I made a table here. Okay, again, I made a table here of the blood supply, the venous drainage, the lymphatics, as well as the muscular layer of the different parts of the esophagus. The esophagus is divided into upper third, middle third, and lower third. Now, some books would just divide it into two. And what are these two? Upper 2/3 and lower 1/3. Okay, which I want you to memorize. You add a middle third. So maging upper 1/3, middle 1/3, and lower 1/3. Now, why is this important? Where is the smooth muscle? Again, where is the smooth muscle? exclusive smooth muscle. It is found in the lower 1/3. And what is the significance of having smooth muscle? Is this voluntary or is this involuntary? Again, what is the significance of having smooth muscle? It is involuntary. So if there is food, a bolus of food, which is found in the lower 1/3, can the patient or the individual voluntarily cough it out? Yes or no? If there is a food bolus or a foreign body found in the lower 1/3, can that individual voluntarily cough it out? The answer is no, because the lower 1/3 is already smooth muscle. Now, tip. The inferior thyroid supplies the upper 1/3. Now, friendly tip. This is the one that came out in the past. What is the blood supply of the upper 1/3 of the esophagus? A lot of people would not believe that the esophagus is, the upper 1/3 is innervated or supplied rather, kasi blood supply is supplied by the inferior thyroid. Eh yung nag-supply, yung pangalan niya, thyroid. Pero it's supplying the esophagus. Now, the venous drainage is the same, inferior thyroid. The lymphatics is very important for cancer. Deep cervical lymph nodes, yung upper 1/3. Mediastinal, that's letter M for middle 1/3. Then we have the celiac lymph nodes in the lower 1/3. Now, question. Okay. Where is the most common location of esophageal cancer? Is it found in the upper 1/3, middle 1/3, or the lower 1/3? Where? Okay, it is found in the middle 1/3. Okay, the middle third is the most common location of esophageal cancer. Very, very important. The lymphatics is very important, especially for cancers and infections, because the esophagus does not have a tunica adventitia, does not have an adventitious layer. Now, anastomosis. Everyone has to memorize this. Most handouts will tell you how many anastomoses. How many? Yung alam nyo. Be honest with me. How many anastomoses do you know? What I was taught in med school was only 3. Okay, I was only taught that there was 3, but I want you to remember there are 4. The first esophageal anastomosis, the first esophageal anastomosis is what we call the left gastric vein. Okay? Left gastric. Left gastric. Okay? So please take note, the esophageal branches of the left gastric, this is portal circulation. Esophageal veins draining the middle third of the esophagus, this is systemic. So what is the significance when the left gastric vein is engorged or if there is high portal pressure? What is the significance? Anyone? Very good. Portal hypertension would lead to esophageal varices. So please take note, these varices are actually the left gastric veins. Okay? So it can be a cause of upper GI bleeding. So when there are esophageal varicosities, this is the most dangerous complication of portal hypertension. Now, can anyone tell me what are the 2 blood vessels? What are the 2 blood vessels What are the two blood vessels that forms the portal vein? Two blood vessels. Letter S yung dalawa. We have splenic vein and we have superior mesenteric vein. Okay, superior mesenteric vein, and we have the splenic vein. So please memorize this. So I hope everyone got this. Now here are some esophageal varices, variceal bleeding. Okay, now question. This came out in the board exam. What is the gold standard in the management of ruptured or bleeding esophageal varices? What is the gold standard? What is the gold standard for bleeding esophageal varices? The gold standard for bleeding esophageal varices. Okay, endoscopy, somatostatin. Okay, what's the gold standard? Management. We're asking for management. We're not asking for diagnosis. Now, tip. Rubber band ligation is the gold standard. Okay. Sclerotherapy is an option, but it is not the gold standard. The insertion of a Sengstaken Blakemore tube, okay, nasogastric tube, is not the gold standard, but it's part of the management. The best answer, best prognosis, best success rate is rubber band ligation. So please take note of this. So please allow me to share this with you. This is lifted from Swartz, okay? Algorithm for variceal bleeding. It says here endoscopic band ligation or sclerotherapy. Number one option is band ligation. It has a better success rate. I'm actually happy that someone mentioned somatostatin. Okay, that's one of the medical management. You can also give vasopressin or octreotide. Balloon tamponade is also an option. And you have nasogastric tubes that has a balloon, and one of them is the famous Sengstaken Blakemore tube. The Sengstaken Blakemore tube has an esophageal and a gastric end. Okay, Sengstaken Blakemore tube. Now, if you want to have lesser chances of the complication, which is hepatic encephalopathy, as well as if tamponade ligation cannot be done or it fails, then you do TIPS. Can anyone tell me what TIPS means? Anong ibig sabihin ng TIPS? Anyone? What does TIPS mean? Okay, it means trans. Anyone? Okay, very good. It's transjugular, intra hepatic ortho systemic shunt. Okay, now tip. Parang that sounded like a pun, huh? Tip regarding tips. This has a complication or side effect, which is hepatic encephalopathy. What shunt, according to Swartz? Okay, I'm probably the only neurologist in the entire country that's going to mention this to you. Okay, I'm reading freaking Swartz, huh? What shunt has the least, okay, chances of hepatic enceph? Okay, perfect. It is a Warren shunt. What is the other name of Warren shunt? What does the surgery book say? It is Warren shunt or hepatorenal shunt. So make sure everyone jots this down. Hepatorenal or a Warren shunt. So please take note of this algorithm for the management of variceal bleeding. Okay, now let's go to the second anastomosis in the esophagus. This is now what we call the rectal anastomosis. So here, I'm going to encircle here. Look at this. Okay, so always remember, this is now the superior rectal veins. This is the one which has communication with the portal circulation. The systemic circulation is the middle and the inferior. If you only have one brain cell left, memorize the superior rectal. Why? If there is portal hypertension, magka-hemorrhoids yung pasyente. What specific blood vessels are involved in the hemorrhoids of a patient with portal hypertension? Sige, let's see if you're following me. What specific blood vessel is involved, okay, if there is portal hypertension? Sinabi ko na, portal hypertension. So if it's portal hypertension, it should be the superior rectal veins. Okay, it should be superior. So what are the common causes of portal hypertension? Okay, one, liver cirrhosis. Okay, pwede liver cancer. Okay, liver cancer. What else can cause portal hypertension? Philippines, schistosomiasis. Very good. Very good. Schistosomiasis. Actually, you see more schistosomiasis. Huh? These are the usual causes of portal hypertension, especially schisto. Just always remember your radiology pearl here, that schistosomiasis presents with a lace-like pattern on the ultrasound of the liver, a lace-like pattern. That is pathognomonic for schistosomiasis. Okay, and your pathology pearl there in schistosomiasis, okay, is the famous pipe stem fibrosis. A pipe stem fibrosis. So please take note of this. Okay, pipe stem fibrosis. So please take note of this. So I hope you guys are following me. So common causes of portal hypertension, liver cirrhosis, liver cancer. There's also schistosomiasis. Now, schistosomiasis usually causes periportal, okay, fibrosis. On ultrasound, it's a lace-like pattern. And the pathology there is a pipe stem fibrosis of the liver. Now, question. If there is schistosomiasis, I'm going very, very textbook, huh? if there's schistosomiasis, is this pre-sinusoidal or post-sinusoidal obstruction? What is the obstruction? Pre or post-sinusoidal? This is pre-sinusoidal obstruction. Can anyone give me the example of post-sinusoidal? What is the famous disease that presents with ascites? Okay, very good. Very good. Galing nyo, ha? It's Budd-Chiari syndrome. Okay, Budd-Chiari. This is hepatic vein thrombosis. Okay, hepatic vein thrombosis. I hope you guys got this. Budd-Chiari syndrome. Now, can I share a secret with you guys? I'm going to show my face here. I'm going to pop up my face here in on your screen. So this is to memorize, okay, the stories Doc Doom tells. Okay, once upon a time, there was a group of medical students. They just passed the board exam. So they said, post-board exams, or pagkatapos inikahuman, post-board exams, let's drink Bud Light Budweiser. Okay, again, it's post. So post-sinusoidal, post-board exam, Bud Light Budweiser. For those who are not familiar, what is Bud Light and Budweiser? What is Bud Light and Budweiser? Okay, they are beer. Okay, so in the Philippines, we have San Mig, we have Red Horse, we have Colt 45. Okay, so this is beer. So can you picture the story? Post exams, mag-inuman, beer. So it's post-sinusoidal, si Budd-Chiari, Bud Light, Budweiser. Now, also remember this story that once upon a time, okay, Dr. Toom saw someone who was jaundice, someone who had hematochezia, okay, a farmer, okay, na diagnosed with schisto. So I simply said, pre, may schisto ka pre. Okay, again, what's the statement by Dr. Toom? Pre, may schisto ka pre. Okay, what is this? Pre, may schisto ka pre. It is pre-sinusoidal. See? Schistosomiasis. Okay? Corny or not? Give me a thumbs up if it's corny. Okay? Meron ba nag-thumbs up? Meron. Sige. Tanggalin sa room. Okay? Corny daw. Corny. Doc, corn. Okay? So just remember that. Ha? Pre. May schisto ka pre. Okay? So I hope you remember that. Let's do anything we can. Huh? All honest means to just remember things. Okay? So I hope everyone got this. Now here, these are the hemorrhoidal piles. Piles are hemorrhoids. Okay? So again, hemorrhoids associated with portal hypertension is superior rectal veins. Okay, superior. And what is that blood vessel again? Which is involved in esophageal varices. What is that blood vessel? Esophageal varices. Come on. Ano yung ugat? Okay. Left gastric vein. Very good. It's the left gastric vein. Okay. Very good. Now, this is now the third anastomosis. This is what we call the para-umbilical anastomosis. So I want everyone to remember basta portal circulation. It's the para, or some books call it peri-umbilical veins. Nandito yung para-umbilical veins. Okay? So what condition do you see on physical exam if there is portal hypertension and there is now varicosities of the para-umbilical veins? What is that medical condition? That is what we call caput medusae. So this is how caput medusae looks like in your more. Okay. You see this in liver cirrhosis. Now here, yeah, oh, look at that. You guys see this? You guys see this? It's a para-umbilical veins. Okay, the umbilicus is here. That's caput medusae. Now here's another picture. Yeah. If you see caput medusae, you know this is portal hypertension. So you can start working up the patient for the etiology of the portal hypertension. It's usually liver in origin. Now, lastly, I mentioned earlier that there are 4 anastomoses, not 3, but 4. This is what we call the retroperitoneal anastomoses. Retroperitoneal anastomoses. Okay, retroperitoneal anastomoses. So take note of this. Basta portal circulation, the veins from the ascending, descending colon, the duodenum, pancreas, and liver. This is what we call the retroperitoneal varicose portocaval anastomosis. Okay, so please take note of this. Okay, so there's a very good question here. How would you differentiate Sister Mary Joseph's nodes with caput medusae? Sister Mary Joseph's nodes are lymph nodes. Okay, this is lymph nodes or lymphadenitis from advanced gastric cancer that has metastasized to the periumbilical lymph nodes. The caput medusae are the paraumbilical veins. So that is the major difference. Okay? Lymph nodes yung Sister Mary Joseph's, while caput medusae is blood vessels. Okay? So please take note of that. Now, looking at this, ascending colon, descending colon, duodenum, pancreas, liver. So please take note, okay? The veins from these areas. Now, Barrett's esophagus. I want everyone to remember this will come out, okay? Now, what is the risk factor for Barrett's esophagus? What medical condition, okay, is the usual risk factor for Barrett's esophagus? It is GERD, gastroesophageal reflux disease. Now, what is the cellular response to injury? Pathology. What is the specific cellular response to injury in Barrett's esophagus? Ano yung cellular response to injury? It is metaplasia. Tamang-tama si intestinal metaplasia. So in metaplasia, one tissue type, okay, changes from another tissue type. Okay. So what is the normal epithelium again? What is the normal epithelium of the esophagus? The esophagus is stratified squamous. What happens in chronic GERD that leads to Barrett's esophagus? The stratified squamous now becomes columnar. Nagpalitan na. And this is the intestinal metaplasia. The hallmark of which in pathology is the presence of the goblet cells. Okay, the presence of the goblet cells is indicative, or the hallmark rather, of Barrett's esophagus. Okay, so please take note of that. Barrett's esophagus. The goblet cells. Now, what are the complications of Barrett's esophagus? Ulceration, bleeding. Okay, there can be the formation of strictures and malignant degeneration. Now, which of these four complications do you think is going to come out in the board exam? Which of these four complications do you think is going to come out in the board exams? Come on, come on. Some are answering bleeding. That's a good answer, but it's not the best answer. Okay, the best answer is malignant degeneration. Why? Barrett's esophagus is pre-malignant. What is the significance of knowing a pre-malignant condition? It is prevention. If you prevent Barrett's esophagus, you are going to prevent esophageal cancer. That is why malignant degeneration is the most important there. Now, so this is something you must remember. Stratified squamous epithelium, non-keratinized. Now changes and it becomes intestinal epithelium. It now becomes simple columnar. This is indicative of metaplasia. Now, let me show you this. This is what basically happens in the timeline. Normal esophagus, you have here stratified squamous, okay? Then it's damaged by GERD, you develop Barrett's esophagus, dysplasia occurs until you develop esophageal cancer. Now, question, what specific histologic type of cancer do you see when it is associated with Barrett's esophagus? Very good. It is adenocarcinoma. Adenocarcinoma for Barrett's esophagus. Most common cancer is still stratified, squamous cell. But in Barrett's esophagus, it's adenocarcinoma. So please take note of this. Now, there is also mention of esophageal motility disorders in your board exam. Okay, and this is number one. It's actually achalasia. Achalasia, you're going to have the presentation of problems with the lower esophageal sphincter. Okay, you're going to have to perform a barium swallow, and you're going to see the famous radiologic finding of the bird's beak. Okay, bird's beak. So the bird's beak is something you have to memorize. A bird's beak. Now, next is the Zenker's diverticulum. Okay, this is actually Zenker's diverticulum. Put a letter R there. So this is a motility disorder in the cricopharyngeus. Zenker's diverticulum, the most common esophageal diverticulum, which usually is found in the Killian's triangle. Treatment is myotomy. Then we can also have an epiphrenic diverticulum, which is a pulsion type of diverticulum. This is usually found in the terminal or the distal third of the thoracic esophagus. Question, what is your diagnosis if you hear corkscrew? What is your diagnosis? Corkscrew esophagus. Okay, it is D, ES. Okay, diffuse esophageal spasm. Now, please take note, you will be assigned to watch the small intestines and the large intestines video in your ECDB, okay? Small intestine and large intestines. I'm almost done with the esophagus. We're just gonna go live with the esophagus, okay? Are there any questions as of now? Okay, so here in achalasia, this is a motility disorder. So what you have to remember is there is incomplete relaxation of the lower esophageal sphincter. Okay, so this is a motility disorder. Now, I want you to remember clinically, this is going to present with progressive dysphagia. It's going to present with regurgitation and chest pain. The Zenker's diverticulum, let me just mention this. The esophageal diverticulum, it usually presents with the same regurgitation, chest pain, dysphagia, but it also presents with bad breath. What is the medical term for bad breath? Okay, what is the medical term for bad breath? Okay, it is halitosis. Okay, halitosis. So please take note of that. Okay, halitosis. Okay, halitosis. So I hope you got this. Now let me just end up showing you this. Okay, what do you see here? What radiologic finding do you see here? Ano ito? What is this? Okay, this is the famous bird's beak. Okay, the bird's beak appearance. Diagnosis. What is your diagnosis here? Okay, the diagnosis is achalasia. So I hope you remember this. Okay, achalasia. So lastly, let's mention esophageal carcinoma. So this is based on your surgery book. So let's make an agreement. If the question comes out in surgery, the winner is Schwartz. Is that clear? Not a journal, not Snell, not Gray's Anatomy, but Schwartz. If this is asked in pathology, what is now the Bible? In pathology, what is it? It is Robbins. And lastly, if this comes out in medicine, what is the Bible? In medicine, it is now Harrison's. In your case, it's Harrison's 21st edition. Is that clear? Kailangan nyo malaman yan because most of you are just reading handouts. Okay? So take note, equally split yung squamous cell and adenocarcinoma in your surgery books. In Robbins and in Harrison's, what is more common is squamous cell. Is that clear? Okay, squamous cell carcinoma is the most common. You encounter adenocarcinoma if this is associated with Barrett's esophagus. Okay, Barrett's esophagus, yung adenocarcinoma. Please take note of that. Okay, adenocarcinoma. So ultrasound is utilized to check resectability. Okay. And this is the criteria for resectability. Number one, the tumor does not penetrate the esophageal wall. Number two, there are less than 5 lymph nodes. Okay. So please take note of that. So most cancers are going to be here in the middle third. Usually presents as dysphagia, GERD. Okay. So please take note of that. Now, we're not going to go into the detail because this will be discussed in your surgery intensive blitz, but I just want to mention you can approach esophageal cancer transhiatal. That means you go through the esophageal hiatus in the diaphragm, okay? Or you can go transthoracic. So I'm going to give you a reading assignment. Read on what is the name of the transhiatal approach and what is the name of the transthoracic approach. Okay, transthoracic and transhiatal. What is the advantage of one over the other? Which has a better success rate, which has better accessibility, okay? And when do you do a transhiatal versus a transthoracic? Okay, so I hope you got that. So this will end our session, our live session on the esophagus. I want you to read on the small intestine and the large intestines, which is found in your ECDB. Okay.